Welcome to the Forum. Conversations on local policy brought to you by the Center for Local Governance. Today we're talking to George Hernandez, CEO of the University Health System in San Antonio, about county indigent care programs. CareLink is a program of the University Health System, and we talked to him about its innovative approach to indigent care.
Well, CareLink is an indigent care program that the University Health System operates. It's a part of our health system family. It's an integrated program, and I guess the best way to describe it is that it has the characteristics of insurance, but it's not insurance. It has an obligation on the member to not only pay a monthly obligation based on his income, but also has co-pays. We then try to structure the program in a way that each member gets a medical home. The goal of the CareLink program is to try to teach the individual member about the healthcare system and make them a party to their own healthcare. Some of the principles are, for example, make sure that there's patient responsibility. That patient responsibility is manifested in a couple of ways, but through a monthly obligation and through a copay. Financially, but they also have responsibilities to make sure they take care of their medication, take their medications and things like that. We also make sure that the patients get their pharmaceuticals. Those are very important. A very inexpensive way to treat patients is to keep them healthy, give them their antibiotics and things like that. We want to make sure they have a medical home, because the medical home, the physician then establishes a relationship with that patient, which then is able to manage that patient care a lot better. University Health System is a large organization. It has about $1 billion budget. So that gives you a little idea that we're not small. We run a level 1 trauma hospital, and we have 17 primary care clinics throughout town. However, we can't do it ourselves. There's about 450,000 uninsured in San Antonio and the surrounding area. So we need partners, and it's cheaper for us to look at CareLink as a payer. And as a payer, we use CareLink to contract with community providers, with federally qualified health centers, with the Center for Healthcare Services, which is the local MHMR facility, with faith-based organizations, and really find a medical home for a CareLink patient. One of the ways we save dollars is that we have control of both sides of the spectrum, not only the payer side of the spectrum, but also the provider side of the spectrum. So we look at utilization trends. We have encounter data regarding our patients. There are people who operate CareLink, are part of our leadership team that work with our hospital folks and our clinic folks. And so when we make changes, everybody's on board as to where we can make the changes to create a win-win for everyone. Pharmaceutical companies came to us and said, look, we know your patients qualify. We know you have a good program called CareLink. We know you qualify your patients. If we can audit your program on an annual basis, and we'll provide you the medications instead of on a case-by-case basis, we'll provide the medications to you in bulk. And the advantage of having them in bulk is if we put them in our pharmacy, it reduces the administrative expense. And so when we were getting $200,000 or $400,000 worth of free medications on a given year, we average now about $15 million worth of free medication from our pharmaceutical companies. And if you look at that on a tax rate basis, in which I like to explain, $15 million is about $0.015 on our property taxes. So it's a significant amount of money. I asked one of our physicians, who's been a real leader in that, Dr. McWilliams, to kind of detail how much we've saved since 1999, and we've saved through free medication about $172 million. Medicaid, I think one of the biggest problems that Medicaid has, it doesn't allow for copays. And copays are a very important technique for us, not to make money so much. We collected about $4 million worth of copays for 50,000 members in 2012, but that wasn't the real purpose. The real purpose was to really change behavior. So we don't have a copay, for example, to see a primary care doctor, and we assign a CareLink member a primary care home. So if you're sick and you need to go to your primary care doctor, no copay. But if you go to the emergency room, there's a $50 copay. I do believe that you're the best judge when you're the county official or the local official about what works or doesn't work in your county. I've instituted things that I believe work in my county because I've had experience growing up there or know folks and we've talked about things. You need to be the best judge of that, but there's certain principles. So I would do a gap analysis of some sort and see where the gaps are in your program and see where we could help.